Okay, so today's plan is to go over pulmonary physiology, get up to where you guys left off in class for today, and then we'll go back and do fetal circulation and see where that takes us. So just to start us off with regular pulmonary physiology, this chart that's shown here is just kind of telling you a bunch of different terminology that you guys should familiarize yourself with. I guess starting with tidal volume, that's the, your normal quiet breathing, how much air you take in just when you're not thinking about breathing. This inspiratory reserve volume is kind of the maximum amount that you have, that inspiratory capacity minus what you normally breathe in. So when you take a deep breath, like how much extra you could fill in by, expanding that chest cavity. You also have the expiratory reserve volume, so how much you could push out, like, compared to the functional residual capacity is like almost like the total amount of oxygen you can have, and residual volume is the amount that's always inside the system. Even if you breathe out maximally, you always have some air in your lungs that you can't actually breathe out. Vital capacity is kind of like this inspiratory capacity plus how much you could maximally breathe out, and total lung capacity factors this vital capacity with this residual volume. And you'll also see this other value called the FEV1, which is how much you could breathe out in the first second. So you could go, that'd be like how much you could breathe out in the first second. And that relates more to the obstructive and restrictive diseases that we'll see a little bit later on. Talking about the pulmonary system in general, we've got the conducting airways. So that's getting gas from one place to another versus gas exchange airways. So it's the actual exchange points of where carbon dioxide and oxygen are really mixing. So conducting airways are kind of from your mouth and your nose all the way down to those terminal bronchioles that aren't actually respiratory, and then you've got your respiratory bronchioles all the way down through the alveoli, which are those individual epithelial cells that you actually can have gas exchange at. So you've got millions of alveoli, and that's like kind of maximally going down to the very, very smallest layer or into the lungs for the respiratory kind of system. And then you want to maximize your surface area for diffusion. So if you were to lay it all out, it'd be kind of like the surface area of a tennis court. You can have so much surface area, but limited volume that you're working with. So trachea, all of this stuff is conducting airways. So it's not the respiratory unit, so there's no exchange, and it's just kind of blowing all the way through up until these points here where you actually start to have that kind of gas exchange. And you see you get more and more alveolar ducts compared to how many trachea you have. You have one trachea, 8 segmental bronchi, etc., etc. So again, in the conducting zone, you don't have gas exchange. It's a low resistance pathway, so the air just kind of goes straight down in. You've got some mucus there to catch pathogens and dust. You're warming and moistening the air that comes through. You're filtering that air, and macrophages also will help clean everything out in that system. With your alveoli, they're very well vascularized, and there's multiple entry points because it is just kind of wherever there is that surface area being exposed, that's where exchange could take place. And they're very, very small, 50 to 100 micrometers. In general, in the respiratory system, we've got a bunch of different ways that tell us whether or not we need to breathe. So we have these chemosensors that talk about carbon dioxide, pH, and oxygen. And so if we remember back to the acid-base dissociation curves, or acid-base curves from, unit 1 with, do we shift, do we compensate, do we not compensate, all of those things, carbon dioxide and pH are your bigger ones, and then you've got oxygen that could kind of also direct how much breathing that you actually do. So typically we've got 100 millimeters of mercury of oxygen in the blood, and if that oxygen gets low, then we start to dictate the breathing rate based on oxygen. People with COPD can become hypoxic, so low oxygen content because they're not breathing enough, because they're not breathing very easily. And remember, COPD is chronic obstructive pulmonary disorder. Mechanics of breathing, so alveolar surface tension, you could think of surface tension as kind of water molecules getting stuck together. And so you have this thing called surfactant, which is a detergent that like kind of breaks up these bonds between that, water, quote unquote. You've got elastic properties of the lung and the chest wall. So you breathe outward, and then so your chest cavities expand, and everything kind of creates this pressure gradient that makes oxygen come in or not. And so you've got elastic recoil, so that's thinking like a balloon. You can recoil, you could push it in, and that'll push air out, versus compliance. So like a plastic bag, you could easily inflate it, but if you tried to compress a plastic bag, it doesn't really blow out that easily. And then you've got airway resistance and breathing work. So the way it works is, for inspiration, you use muscles, and for expiration, normally you don't have to use any muscle contraction. So for inspiration, what you do is you'll breathe outward, and your chest cavity expands. And then so there's an outward force on the ribs, so everything goes out, and then your lungs start to open up, and then it creates a negative pressure on the inside, and that negative pressure, because you go from high to low pressure, all that air outside will come inside to the lungs. And then when you have expiration, you can, it'll just relax, so the chest cavity starts to come back in, and then you've got this pressure where it's a built-up pressure that kind of will just expand outward again. So again, you've got a chest wall with all of these different components, the pleura, serous membrane, and different layers that all do different things. There's a term called orthopnea that you might need to know for clinical cases, and that's just referring to whether or not you could breathe lying down. So people with orthopnea can't breathe lying down, and that's just due to a problem because they can't inspire correctly, so their chest cavities won't expand properly, and then you can't create that negative pressure gradient. Mechanics of breathing, so you've got accessory muscles that are so you've got muscles like the diaphragm and intercostal muscles that kind of move your ribs when you're breathing in, but then when you're breathing out, you don't move the ribs. It's only during active expiration. So accessory muscles typically aren't used unless you're going and actually breathing out with your the rest of the body. Let's see. So you've got other muscles involved in ventilation, like the trapezius is to raise your shoulders, scapula, it's also part of the system, but not everything actually moves your ribs, or not everything actually moves your lungs. It's just other parts of the body that kind of deal with it. Gas transport, basically the biggest thing is oxygen has to get in, carbon dioxide has to get out, and you've got fresh oxygen coming in, and then oxygen will bind to hemoglobin. HB is how it's abbreviated, and hemoglobin is that normal carrier for oxygen around the system, and then it'll drop it off at tissues, and then once it's dropped off at tissues, it can pick up, carbon dioxide can get picked up by the blood system. So oxygen has to get through multiple layers, so there's like a surfactant layer, alveolar cells, a basement membrane, endothelial cell, blood, red blood cell membrane, and then it finally can get to the hemoglobin. So you need a strong membrane for that blood in general, and just basically like there's a lot of layers that oxygen has to go through to actually get to where it needs to go to. So this table is probably a good test for your understanding of the pulmonary system. So first off, in the lungs, this is where you get as much oxygen as you can, and you're trying to get rid of all of that excess CO2. And then the water and the nitrogen values aren't really as important, so you can kind of ignore them. But in the pulmonary side, so red in this case is oxygenated blood. So we've got an oxygenated blood pressure of 100 millimeters of mercury. And then we've got here carbon dioxide is 40. And so what that means is we've got a high oxygen coming in so that we can drop it off at the tissue. So the tissue only has oxygen of 40. So 100 is greater than 40. So oxygen gets dropped off at the tissue. But then we've got a carbon dioxide of 46 versus 40. So because we've got higher at the tissues than in the blood will take the CO2 with it and leave while dropping off O2. And so that's kind of the biggest key component about the pulmonary system or blood circulation. So oxygen high in the arterial side drops off oxygen, picks up carbon dioxide, and now it's deoxygenated, and then you bring it back to the lungs to get inspired out and get more oxygen in. So is it?
Mm-hmm.
This is a very important curve to know. It's called the oxygen-hemoglobin dissociation curve. Oxyhemoglobin dissociation curve. So the way I abbreviate things, it's much more simple that way. So basically, you have a normal curve, and it can either shift left or right depending on whether or not you want to pick up more oxygen or less oxygen. So one hemoglobin can pick up 4 oxygen molecules. And so if we think about these different factors of like what does decreased versus increased affinity mean? So we have decreased affinity if we have, for example, a high CO2, a high temperature, a high 2,3 DPG, which is just another like factor associated with all of this. I don't think you need to know that one as much. And then in this case, a decreased affinity means you let go of oxygen easier. So if you got a lot of CO2, a high temperature in the system, or a low pH, you shift to the right and decrease affinity. So the way I wrote it here is just kind of like a reminder. So all of these things lead to a shift to the right and a decreased affinity. So it's kind of like up, 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 shift right, down, down. Or it's like low CO2, low temperature, low 2,3 DPG. You shift left, or an increased pH could also make it shift left. And you have a higher affinity, so you pick up more oxygen. So you're less likely to drop oxygen off at the desired locations. So I think he talks... Okay. So in some cases, like, the reason why there is this like left or right shift, it's just thinking about like what is best for the cell at the time. And so, if you have a lot of carbon dioxide in the system, you want to get oxygen to the rest of the system. And you want to more easily say like, okay, you've got a lot of CO2, now let's give you some oxygen just so you can breathe better. Versus like if you don't have a lot of CO2, you want to just kind of like pick up the oxygen and stuff like that. I think it's easier to just kind of memorize these kind of numbers or arrows. It'll help. Or put it on your cheat sheet, something like that. So carbon dioxide transport, carbon dioxide is more soluble in the blood than oxygen. And so typically you'll see it dissolved in the plasma as a bicarbonate form or attached to proteins, whereas oxygen is always like 95% on like the hemoglobin, and it's very insoluble. There is this equation for solving what the oxygen content is that I would put on the cheat sheet. So it's O2 content in milliliters per deciliter or volume percentage equals 1.34 times the hemoglobin concentration times the O2 saturation. And then there is this like optional like plus 0.003 times PO2, but that's kind of negligible, and so it's like this first part of the equation is what I would go with. But I would double check on previous exams whether or not he includes like this part that I have here in orange, whether or not that part is important for calculations on your exam. Let's see. This is more about the direction of blood flow. We'll go over that later. Pulmonary circulation. So in general, if something is hypoxic, you send it more blood. If the lung is hypoxic, you send less blood because you don't want hypertension, and like you don't want to like take away oxygen from that or anything like that. Hypoxic vasoconstriction. Let's see. So that's caused by a low alveolar oxygen content. Blood gets shunted here or there just to make sure you can get as much oxygen perfusion as you could possibly get. And then acidemia is another factor of pulmonary artery constriction. So that kind of relates to this figure here. So what you see is if you have impaired ventilation, it's your blood is kind of blue because it's not oxygenated as well. You could have a collapsed alveolus, which is like a reason what could happen. So you have very low ventilation to this side of the alveoli, this part of the lung, versus this part. You do actually get some oxygen kind of coming to this area. It's just insufficient. It's not very much. So like the normal in this case, it's like blood comes in, can get properly reoxygenated, versus blood oxygen wants to come in, but it can't properly fill the lung, and it can't properly like diffuse into the bloodstream. This part is like the lung is collapsed because of like a complete blockage, so like no oxygen gets picked up by the blood, and then this one is like just dead space, so you kind of just ignore that. So you have blood, but it's not really getting through. So with the lungs, you've got like 3 major regions, zone 1, 2, and 3. And so in the middle zone is the best matching of ventilation and perfusion. And then at the lungs, at the very apex, the top part, you see that it's properly matched between the alveoli. The alveoli get more open because it's like they get full better, versus like here the lung is less stretched, so the alveoli open up less. So the biggest idea is that you get the proper ventilation perfusion in this middle zone. Different tests for pulmonary function. The ones you should really know are the functional vital capacity, FVC. So that's like how much oxygen you could have, how much volume you could have total, versus the forced expiration volume, FEV1. So how much you could expire in 1 second of that FVC, of that total. And so the reason why that's important is if you look at this kind of graph, it'll kind of divide everything up. So like how much you could possibly inspire, how much you could possibly expire, how much is always left in the lungs. Functional vital capacity is like everything, kind of almost everything added together. Total lung capacity is how much volume, like the total. Let's see. So in fetal lungs, what you have is a job for like your the lungs have to develop properly, and oxygen comes from the placenta, and then after about 28 weeks, 24 to 28 weeks, that kind of time, you start to need surfactant, and the surfactant will help the lungs properly, I guess, start to open up and start to work properly and stuff like that. So cortisol triggers the maturation of those surfactant producing cells, and they're called type 1 and type 2 alveolar cells. and I think it's type 2 that secretes that surfactant, whereas type 1 doesn't. But you finish off the maturation of the lungs basically once you're born, and so you start to need surfactant, and then once you actually are born, that's when you can start producing it on your own, and you're completely mature. Pulmonary physiology, basically, like, I would read through all of these definitions and include the ones that sound confusing, like, on your cheat sheet. So just to go over a couple, so dyspnea, difficulty breathing. Orthopnea, remember, it's difficult to breathe when you're lying down. Kussmaul respiration, you'll see that in your clinical cases. That's like rapid shallow breathing. Cheyne-Stokes respirations, that's more like you're alternating between no breathing and very rapid breathing, and it's very easy for patients to die from Cheyne-Stokes respirations. Hypoventilation, you're not breathing very quickly. Over breathing. Cyanosis is like, is your blood blue because it's deoxygenated? So that's a low O2 content. Hypoxia is versus hypoxemia deals with where the blood concentration is low. So like hypoxemia is more like the arteries, and hypoxia is more like general blood kind of in the system. You could have clubbing of like your fingers, so your fingers could get kind of misshapen. Hemoptysis means coughing up blood, and then you could have different forms of pain. And then you have a bunch of different injuries that you should read through. For the different pneumothoraxes, I would keep that on my cheat sheet, or at least know the difference between like open versus tension versus secondary versus spontaneous, because he might ask about that. So open pneumothorax, that's like normally it's a chamber full of gas between the pleural space and outside, but if something like punctures that area, that like there is now gas exchange, then that's bad. If a tension pneumothorax is like the pleural space has been penetrated somehow and gas gets leaked out, versus secondary, which is caused by another lung problem, and spontaneous is idiopathic, so you don't actually know what the cause is. And then all of these different effusions I would also know. So transidative refers to a low protein content, exudative, high protein content, hemothorax, hemo, blood, thorax, pleural space, chylo, lymph, epiema, the means pus in the pleural space, and then you could have mechanical problems, so chest wall restriction or flail chest. So because with flail chest, you'll have fractured ribs that interfere with your breathing. Pathogenesis of pulmonary edema, so it's common in congestive heart failure. So you could have some sort of valvular problem that leads to like increased pressure in the left side of the system because it's just not getting properly, it's not working on that side. And if it's not working, then you can build up pressure in like the lung system, and that can kind of feed back onto your actual lungs, and you have edema there. You could have ARD, so acute respiratory distress due to infection. So you have injury to your endothelium, proteins start leaking out, and because proteins leak out, then kind of fluid kind of moves to where that protein is, and that's what could cause the edema. Or if you just have like a blockage of lymphatic vessels, lymph gets actually built up there, and then eventually, again, like excess lymph buildup makes the fluid accumulate in that space, and then that can also lead to edema. I think I put this on my cheat sheet. Pretty sure I did. Absorption atelectasis. So basically, it's good to take a deep breath every once in a while, because it'll make sure that any clogged pores will kind of open up the oxygen. So deep breathing will kind of like open this mucus plug back up. And sometimes you have these small alveolar clogs where gas just doesn't move, but that deep breath will force this area open and try to like break up this little plug here and make things a little bit easier. You can live on only one lung as well. So this is going back to what a pneumothorax looks like. So with a pneumothorax, your ribs, they want to expand outward, but your lungs are kind of collapsing inward. So outside air enters because of disruption. Lung air enters this disrupted area. And so you hear diminished lung sounds that you'll kind of notice on your clinical cases. Flailed chest. So a normal chest is like normal, lungs breathing outward, like chest expanding and then coming back. But then with broken ribs, it kind of does the opposite. So when you want to breathe in, they kind of collapse inward, and when you want to breathe out, they push out, like your ribs kind of push outward. So it's very painful and very difficult for oxygen to really get into the system and out of the system properly. So with pulmonary disorders, you've got your restrictive and your obstructive lung diseases, and I guess you can read through all of those. So with restrictive pulmonary disorders, the biggest thing is that it's difficult to get air in. So you have a decreased FVC, so that functional vital capacity, so how much you could totally breathe in, versus with, also note with the restrictive pulmonary disorders, you are perfectly fine breathing out. So FEV1 is normal, just decreased FVC. Whereas with obstructive pulmonary disorders, you have a decreased FEV1, so you can't breathe out as quickly, and so that makes your ratio actually decreased of FEV1 over FVC. So how much you could breathe out in without 1 second over how much you have total. So with obstructive pulmonary disorders, you've got three main ones: asthma, emphysema, which is different than that empyema we talked about earlier, pus in the blood vessels, and then chronic bronchitis. So this is talking about COPD, chronic obstructive pulmonary disorder. So remember, normally when you inhale, there's a negative pressure which causes oxygen to come in. But if you have a mucus plug that blocks you on the way in, it doesn't really affect you, air can get through. But if you're trying to breathe out, you kind of contract on the system. So this airway, it's like completely blocked by that mucus plug, and if this is completely blocked, you can't push the air out. Pathophysiology of asthma. So asthma is very similar to that case. There's just an overproduction of it's like a hypersensitivity response to an irritant. So then everything kind of gets plugged up with too much mucus, and when there's too much mucus, this vascular congestion, you have airway obstruction. And so asthma is very similar to kind of COPD, but not quite the same. And then let's see, so chronic bronchitis versus emphysema. So together these two both make up like subsets of COPD as like a whole. So with chronic obstructive pulmonary disease, we've got these two categories. Chronic bronchitis, you've just got mucus hypersecretion, so again, it's difficult to breathe out. But this one is like, you've got, instead of small alveoli, they look kind of like melons. They're very, very big, and you lose out on the surface area, and you also lose out on that the elastic recoil. So you can't really force the air out as efficiently if they're like these giant alveoli rather than these tiny little alveoli. So with chronic bronchitis, hypersecretion of mucus, and it's just very, very difficult to breathe out. It's very thick mucus. Emphysema, you have giant alveolus, so you lose the elastic recoil, and it could be, he doesn't differentiate centra versus pan acinar, but pan would be like everywhere, centri is just one location. This slide we can skip with the normal versus, so it's just the difference between the two. I don't think you need to know them. Yeah. So then, so again, asthma is this like overreactive, like hypersensitivity. So you make a lot of mucus. Chronic bronchitis is like you make a lot of mucus and it's also very thick mucus. Emphysema is you lose that elastic recoil and it's difficult to exhale. So all three of them very difficult to exhale. Moving on to restrictive lung diseases. Restrictive lung diseases, you reduce the all of these. So you reduce the FEV1 and the FVC, but you kind of the ratio is normal and the expiratory flow rate is normal. So that differs than the obstructive, where obstructive is you decreased the how much you could breathe out in that first second, and it's relatively normal, that FVC, like how much you could totally breathe inward.
You stop there.
Okay, cool. So we'll just we'll stop here, and then we'll transition over to fetal circulation. See how much we can get through. So with fetal circulation, the biggest idea is to know kind of like what direction all of the blood is moving in. So there's these special components that are only particular to the fetal circulation that are not in normal circulation. So you've got obviously umbilical arteries, umbilical veins that you don't see, but you also have this thing called the foramen ovale, and that's like a connection between the right atria and the left atria. And so that's important because in fetuses, they don't need their lungs. So their lungs are underdeveloped because you get oxygen from the placenta. So blood doesn't really need to go to the lungs. So you just have this oxygenated blood just kind of going through to the left atrium directly. Like you don't really need that pathway to the lungs just yet. And then you have this other thing called the ductus arteriosus, and that's a connection right here between like the pulmonary artery and the aorta, because again, you don't really need to go to the lungs, but that blood just kind of goes to the rest of the system. And so these two things, so a ductus arteriosus is just like a duct that remains open, this connection, and it theoretically does go away. It's supposed to close up, and you're supposed to then separate lungs from the systemic circulation, but you'll see later in these problems that it could be a problem. So this is just outlining what all of that is in more formal detail. I'm not going to read through it, but you guys can. So in general, like, we'll skip this. You're basically going to have a list of all of these different congenital heart defects, and you're just going to have to know like all of them basically. But it's not really that difficult like once you kind of get the gist of it. So the biggest theme is it cyanotic versus acyanotic? And so if it's cyanotic, what that means is you are deoxygenated, you don't have oxygen, it's blue blood basically, cyan. Acyanotic, it's oxygenated, so you do have O2. So what can happen is you can have these things called shunts. So normally blood would go, unidirectionally, one side to the other. But if for some reason there's a pressure buildup, or you have this what's called an atrial septal defect or a ventricular septal defect, on this page it shows you a little better. You have this region. The septum typically separates left from right, but if the septum gets, for some reason, defective, and you can actually leave space between the two, then whichever side has the greater pressure dictates the blood flow direction. So normally, you would just not see blood being able to get through left to right. So this is the normal foramen ovale. But if for some reason we have an opening here, the left side heart usually has higher pressure than the right side, so blood would get forced from high pressure on the left side through to the right side, and you would have less blood flow basically. And then you also have another case called tetralogy of Fallot, which we'll talk about later, which involves a right to left shunt. So atrial septal defect is a left to right shunt from the left atria to the right atria. And so that septum that's supposed to separate the two atria is defective, so blood can now flow through, and it'll more blood will flow into the lungs. It's acyanotic because we're not actually like deoxygenated anywhere. A ventricular septal defect is kind of the same thing, just with the ventricles, left ventricle to the right ventricle. But in this case, what can happen is your left ventricle, it starts to like hypertrophy because it needs to pump a little bit harder to get, you know, all of that blood out to the rest of the system. So if it's a small ventricular septal defect, small hole, doesn't matter. If it's a large defect, it's very difficult because then you've got like a lot of blood that you're losing here, a lot of increased blood going to the lungs, which feeds back into the left side, so it's like even more blood than it's used to, and it has to keep pumping harder to really get that blood out of the system. And over time, that right ventricular pressure could like get close to the left ventricular pressure, and this will increase pressure on the pulmonary system because this pressure is building up here, and if this pressure builds up here, the lung pressure will build up and you can lead to hypertension. You can have this thing called an atrioventricular canal defect. So two valves fuse and they won't separate, and so the problem with that is the pulmonary arterial pressure will equal the pulmonary the pressure of the aorta, and that causes hypertension, and you get slight mixing of the blood but not enough to make you cyanotic. So typically it's supposed to be like the, you know, atria and the ventricles are supposed to remain separate, but for some reason the blood can mix here. The two valves actually are fusing and they won't separate, and so the blood kind of can go out and mix where it shouldn't. A patent ductus arteriosus. This problem is there's like a connection from the aorta into the lungs that we still maintain. So if you remember earlier, what I said is that it's supposed to close off, and when it closes off, it's supposed to just kind of separate the pulmonary from the systemic circulation. But in this case, it's not separated, so that can cause less blood going to the body, too much going to the lungs, and that again can lead to hypertension. And a patent ductus arteriosus, because blood is constantly flowing from the like from this side to this side, then we've got this continuous murmur that kind of sounds like a machine, and so you'll hear a continuous murmur for clinical cases, like it'll mention that, and it might refer to this patent ductus arteriosus, PDA. And then, so in general, left to right shunts are acyanotic because oxygen gets to the system normally, but, and like no problem happens with like properly getting the right side oxygenated in the lungs. You just increase pulmonary blood flow, so more blood goes into the lungs, which can cause like hypertension and other problems like that. A coarctation is a narrowing of the aorta. So there's a pre and a post ductal. So that's like after that, like patent ductus arteriosus kind of duct is what this kind of thing refers to. But if it's after the duct and you have narrowing, then all you see is that blood can more easily get to the upper body because it's up here before the narrowing, the subclavian artery. But if the blood that needs to go to the rest of the body is after this narrowing, then you have a lower blood pressure in the lower body. So you have a weak pedal pulse, weak foot pulse, versus a high blood pressure in the upper body, so strong radial pulse. And so what you might end up seeing is high renin production because your kidneys are in your lower part of the body, and they see that like less blood can get through here because the narrowing cut it off, and so you kind of increase the renin production to increase blood pressure again. But Your upper body is fine because the subclavian artery is before that ductus arteriosus, that like narrowing that occurs. Preductal, on the other hand, so the narrowing occurs there, and you have like this left to right shunt again through the ductus arteriosus, which increases blood volume into the lungs, into the pulmonary circulation, which causes increased volume to come to the left side. If more volume is on the left side, it has to work harder. If the left side has to work harder, then you hypertrophy. And if you hypertrophy, the left side could end up failing, and that could lead to, or that's because of like a congestive heart failure, quote unquote. So increased return from the lungs, and your decreased ventricular output, like, so this has to work harder, but there's also more fluid, so it causes the left side to just like fail because it can't properly get it out. So again, in extreme cases, there could be a complete coarctation. That would be like if the pulmonary artery causes the right side to go to the left side, and the pulmonary artery could end up feeding the body, and you could see cyanosis in that lower body. So you could have warm pink hands and cold blue feet. But this case isn't as talked about. So again, postductal and preductal coarctation of the aorta has to do with acyanosis due to obstruction of the blood flow from the ventricles. Alright, so we will end there today, and I'll finish everything up next time.